So anyways, just to go ahead and get started, we just wanted to sort of run through what we see usually for any type of initial visit. And so usually within an initial visit for any type of provider, we're interested in, first of all, making sure that the person is coming in, if we're talking about depression, how depressed are they, and how can we do that? And I understand that several people in here have mentioned that they've used standardized screening tools, for example, like the PHQ-9. Somebody else earlier today had mentioned the Beck Depression Inventory Scale. So there are many different types of standardized approaches that are out there, and we'll talk about one of them, the PHQ-9, which stands for the Patient Health Questionnaire. And we'll go through each of those questions for you. We'll also talk about education. We'll talk about treatment options. And then we'll talk a little bit about, starting up an initial treatment plan, some of the issues around that. And, the main thing that happens is that in any kind of visit, the biggest thing is not only just talking about the treatment options and starting up the treatment plan, but really coming up with a plan for follow-up to make sure that they're going to come back in, whether you're going to talk to them in person or by phone or have somebody else help you out with that. And we really want them to come back in about a week to really check in. And part of that comes down to one of the issues that was raised earlier about potential side effects with medications. If you're going to start up with something, what is going to happen? What are you going to feel like? And at some point, all patients are going to have these sort of questions. They need to have these sort of things answered. And then the final thing is making sure that we document the initial visit so that we know what happened, because as we all know in our busy practices, what happened 1 week ago, we're going to forget. So it's always important to make sure that we document what we talked about and what our plans have been. So just to make sure that we're all on the same page, we just wanted to make sure that we talk a little bit about the different types of depression symptoms. And so usually when we're talking about depression symptoms, we're talking about people who have a depressed mood and or loss of interest or pleasure. And so sometimes you'll hear the clinical term anhedonia, but what that really just means is that they have a loss of interest in their typical activities that they used to do for fun, that they found enjoyable. And then there are also some physical and vegetative symptoms that go along with depression, and we'll also talk a little bit about some of these physical and vegetative signs. And then we'll also talk about thoughts of death or suicide and what you might hear from a patient if they're thinking about these sort of thoughts. So when we talk about depressed mood or anhedonia or loss of interest or pleasure, these are the sort of terms that you'll get from a patient. They'll tell you that they're sad, that they're feeling tearful, that they're feeling guilty about certain experiences, that they're pessimistic, that they have this sense of failure, self-dislike, dissatisfaction, irritability, social withdrawal, self-harm, apathy, or, again, lack of pleasurable activities. I'm sure we have all met a patient that has these symptoms. In terms of physical or vegetative symptoms that you'll see for patients who have depression, they might tell you that they're having trouble sleeping or that they might be sleeping too much. So it's actually on both sides of that spectrum. So it's not just one side of that. This also includes early morning awakening. They often will tell you that they're having trouble concentrating, that they have decreased energy, that they might have decreased sexual interest, loss of appetite, or, again, sometimes they'll move to that other side of the spectrum where they're actually overeating instead of having that loss of appetite. They might mention that they're having digestive problems, constipation, bowel irregularities, or aches and pains. And oftentimes for patients who are coming from different backgrounds who are not necessarily born in the United States, they often will talk about these physical symptoms a lot more than telling you that I'm feeling depressed. So it's really important when we start hearing about some of these physical ailments, when we hear more complaints about that, we want to make sure that we actually also investigate and see whether or not they really are depressed. Just some other signs that might also show up in terms of patients being depressed. They might have a disheveled appearance, compared to what they normally would look like. They might have difficulty sitting still. In other words, they might be restless. Or, on the other hand, they may also have slowed speech or slowed movements or also reactions. And then finally, you always want to make sure that if you're thinking that somebody is depressed, you really want to find out if they have thoughts of death or of hurting themselves, and you also want to find out if they've ever tried it before, if they've ever actually attempted suicide, and if they have any sort of current plans about that. So I don't know, Bone, if you wanted to talk more about this or not. I mean, I can certainly go through it.
This talk was originally actually designed for primary care physicians who aren't, and most people here have strong mental health background. So I think everybody here feels comfortable with talking about these things. Am I right? Yeah.
Okay.
Oh, sorry. So that's why the talk was framed this way. I think the only two things that I would add is for older people or even other people, they'll say they're bored. Apathy translates into I'm not interested in anything. I'm really bored. Nothing seems fun. So that's what anhedonia looks like. Just to go through suicidality, everybody feels comfortable talking with their patients about suicidality, right? Does everybody feel? I'm never quite comfortable, but I mean I know how to do it now. Everybody feels comfortable. You guys in the back feel comfortable? Okay.
I don't.
You don't. Well, Peter. Yeah. We can talk about it later.
Okay.
One of the things you want to ask people who are depressed. Obviously, we'll go through this very quickly. Do you feel like hurting yourself? Have you had any accidents in the last month or two? And in those accidents, did you mean to actually run into that tree? Especially for men. You want to assess any current plans because a lot of people walk around with suicidality like all the time, right? So, or they think about death all the time.
One of my providers actually had me write a no-suicide contract. We've never used it, but if the provider feels that this patient might be suicidal.
I mean, we do that. Go through suicide contracts with patients.
Okay. So does it work for you?
The evidence actually, this is going a little away from the talk, the evidence on suicide contracts is actually pretty equivocal, meaning that it's not clear that it necessarily works, at least in the studies that I've seen. So, but I don't think it's a bad thing to do. I think just because it's not clear that it does work doesn't mean that it doesn't, but I think it's a reasonable thing to do. Go to the next slide. If we go through the previous slide, you just want to look at prior attempts. You want to look at hopelessness. Older males who are living alone, especially if they drink, really they're at high risk. People with anxiety disorders, so if you have panic and people's really worried and nervous with depression, they're also at high risk. People who have things like cancer or may have just had a heart attack, potentially terminal illnesses, they're also at risk as well. So I want to go down. Diagnosing depression. So you want to figure out whether people meet criteria for depression, meet criteria for dysthymia, which is kind of a minor depression. What if patients meet neither criteria? What do you do then? For major depression, you want to have the symptoms of depression. You want to have them nearly every day for 2 weeks or more. And you don't want to diagnose someone depressed if they've just lost their loved one, like a son, a daughter, a parent, a best friend. You want to give them a couple months. And also if there's mania. Let's see. You want to have 5 or 9. You want to have 5 or more of the 9 symptoms. You can have either the depressed mood or anhedonia because not everybody knows what depressed mood is. I think minorities, men, they don't talk about feelings. We don't talk about our feelings. But they do talk about boredom or being angry. And then you want some of the other symptoms on the left-hand side, like weight changes, the energy changes, the fatigue, worthlessness, guilt, thoughts of death, concentration. Anyway, and I'll turn it back over to Mike.